Please allow me to introduce Dr. Mack. Dr. Mack has practiced cardiothoracic surgery in Dallas, Texas since 1982. He is board certified in internal medicine, general surgery, and thoracic surgery, and is currently the director of the cardiovascular service line for the Baylor Scott & White Health System. He's the chair of the Baylor Scott & White Cardiovascular Governance Council and the president of the Baylor Scott & White Research Institute. He has over 800 peer-reviewed publications. Dr. Mack is also the senior vice chair of the Cardiothoracic Surgery Network of the NIH and is an associate editor of JACC, as well as a member of the American College of Cardiology Nominating Committee, ACC Governance Committee, ACC Innovations Work Group, and is the co-chair of the STS-ACC National Transcatheter Valve Therapy Registry Stakeholder Advisory Group, and a member of the FDA MD EpiNet Advisory Committee. He is currently a director of the American Board of Thoracic Surgery. Dr. Mack was president of the Society of Thoracic Surgeons in 2011 and is past president of the Thoracic Surgery Foundation for Research and Education. He was the master of the ACC and is an honorary member of the German Society for Thoracic and Cardiovascular Surgery and the Indian Association of Cardiovascular and Thoracic Surgery, Mexican Society of Cardiac Surgery, and has received the Presidential Citation of the American College of Cardiology and the Transcatheter Cardiovascular Therapeutics Lifetime Achievement Award. Thank you very much, Michael Mack. We're very excited to have you with us this morning.
Thank you, Marty, and Dr. Fuster. Appreciate you inviting me to give this Grand Rounds talk. So what I'm going to talk about this morning is what is the future of cardiac surgery, and hopefully this is something a little bit different from what you have maybe heard before. This is my conflict of interest disclosure, being in the trial leadership of 3 different trials for 3 device sponsors. So is thoracic surgery an endangered specialty? Some would lead you to think that it is. I was debating coronary artery bypass grafting versus PCI with Patrick Sarice in 1999, and he predicted at that time that CABG surgery will be dead within 10 years. If we look at the latest treatment of aortic stenosis, again, it looks like cardiac surgery is kind of on its heels, and TAVR has shown a relentless penetration into the treatment of patients with aortic stenosis, with the number of isolated aortic valve replacements, aortic valve plus CABG, and aortic plus mitral valve decreasing significantly over the last decade. So as Shakespeare said in The Tempest, whereof what is past is prologue. So what I will talk about is where we have been in cardiac surgery, where we are now, and where we are going. So I briefly can sum up the history of thoracic surgery, and cardiac surgery started out as thoracic surgery, as staying one operation ahead of extinction. And I think there are many examples of that. The specialty of thoracic surgery started for the treatment of tuberculosis in the late 1890s. And you can see here multiple procedures from thoracoscopy to thoracoplasty to plombage that was done for the treatment of tuberculosis. And there were a lot of very creative operations done. Arguably, the first operation ever done was a thoracic procedure, surgery procedure by Hippocrates for the drainage of a tuberculous empyema. But all of this was replaced with the invention of streptomycin, and the origins of the specialty moved on to something else. Rigid bronchoscopy became a mainstay of the specialty in the 1900s. And that was replaced by bronchoscopy with fiber optic bronchoscopy, replacing surgical bronchoscopy, and the specialty moving on to pulmonology. Next is the specialty took on the treatment of rheumatic heart disease, with balloon mitral valvuloplasty being a prominent part of the specialty in the 1940s and 1950s. However, when penicillin came in, again, the specialty had moved on from rheumatic heart disease, and those patients that still were left could be treated with balloon mitral valvuloplasty. Pacemakers were an early part of the legacy of cardiac surgery, with the first pacemaker being on the left in a surgical patient with Lillehei at the University of Minnesota. And then this first report of an intracardiac pacemaker for Stokes-Adams seizures in 1959 in the New England Journal. But it was such a large size that it required a surgeon to be able to implant this device. But as we now know, with smaller pacemakers and leadless pacemakers, this specialty has moved from cardiac surgery onto electrophysiology. And the same thing with defibrillators. The early defibrillators were so large it required a surgical implantation, but technology improved. And now, of course, it's an EP procedure with much smaller defibrillators present. The heyday of cardiac surgery was probably in the 1960s, where the specialty made the cover of Life magazine and Time magazine here in 1967, with the first heart transplant being performed. Surgeons made the cover of Time magazine, DeBakey working for total artificial heart, and then DeVries with a total artificial heart. And even the feuds of cardiac surgeon made the covers of national magazines at the time. I must say, I think that the lay press coverage and the larger than life individuals that these surgeons came influenced a number of individuals, probably subliminally myself also, to enter the specialty of cardiac surgery. And then coronary revascularization, beginning in the mid 1960s, clearly became the focus of the specialty, but again, only to be replaced by a less invasive approach, PCI. And now we see that TAVR is gradually replacing SAVR as the treatment of patients with aortic stenosis. And indeed, this is the total treatment of the aortic valve in the United States. You can see as of 2018 that the total number of surgical procedures on blue line on the top was about 70,000. And last year, despite the pandemic, it's estimated there are about 74,000 patients that got TAVR in the United States. So again, what's cardiac surgery going to do to stay one operation ahead of extinction? And we now know that more and more patients are being treated by what's now being called transcatheter edge-to-edge repair with a MitraClip device in the United States. So how is cardiac surgery? Its legacy is being staying one operation ahead of extinction. What does it segue to next? Well, as we all know, the treatment of heart disease continues to change, and you can argue whether it's for the better or for the worse, but it clearly is changing. This is a slide from Professor Frederick Moore from Leipzig in his presidential address to the European Society. Learning and innovation go hand in hand. The arrogance of success is to think that what you did yesterday will be sufficient for tomorrow. So what is the road from here? Well, I think there's some basic principles of any surgical procedure that help give direction as to the way a specialty needs to evolve. The first is that, as Einstein is known to have said, everything should be made as simple as possible, but no simpler. And I think if we hold with that principle, you can find the right balance. There's a cardiac surgeon in the Bay Area of California named Vince Gaudiani, who David Adams knows very well, but Vince was a surgeon, did big case surgery. But I had asked him a couple years ago for his thoughts on the specialty and where it was evolving. And what I'm going to share is some of his thoughts that I thought were very insightful from somebody who totally embraced complex, large cardiac operations. If you have to be a master surgeon to perform an operation, then the operation is not widely adoptable nor of significant value. If only a few masters can do it, then you are not delivering effective health care or surgical cardiac surgery care in this instance to the masses. And under big case surgery, what Dr. Gaudiani defined as Whipple procedures for pancreatic cancer, radical mastectomy, open abdominal aortic aneurysm repair, esophagectomy, and circulatory arrest arch surgery, all huge, big operations. And there are three more thoughts he had on this. First is the decline of big case surgery began before we started training. It was always the product of an age in which it developed, and that age has passed and it will decline. Big case surgery depend heavily on the technique of the operator. They are complex, and the physiologic consequences of the procedure are major, independent of the success of the operations. And these were a consequence of a particular moment in history that has passed. The device part of this revolution reduced the necessity for technique by building more of the solution into the technology. Technique would remain important, but far less so. Therefore, outcomes are more dependent on the device than they are the technical ability of the operator. And I don't think we have to look any farther than a PCI for coronary artery disease to understand why this example is successful. It's not to demean the technique or minimize the technique of PCI by any means, but the invention of the stent totally changed that procedure. I remember the early days only that too well in the pre-stent era. But the same thing is true in cardiac surgery. This is a quote from Denton Cooley regarding the invention of the heart-lung machine and its introduction into cardiac surgery. The worst thing that happened to me was the invention of the heart-lung machine, because that any pedestrian surgeon could do heart surgery. And again, it bespeaks to the fact that you have to be able to make a procedure friendly to the average surgeon to be able to effectively deliver care to large numbers of people. That master surgeons such as Cooley weren't sufficient in and of itself. As Dr. Goldman said, I've written a lot of publications over the years, but probably the one I thought most about and to this day I think provided the most insight, at least for me, was in this Millennium issue of JAMA, published in 2001. And it asked about 20 or 30 specialists from different procedures to predict what's going to happen in the 21st millennium. And I was asked to speak on to write on minimally invasive and robotic surgery. And this was a task that was way above my head, but I knew enough people to be able to ask and to take an informal survey. So I talked to multiple different specialists, from orthopedic surgery to laparoscopic surgery, ear, nose, and throat surgery, neurosurgery, and the four principles all came through. And remember, this was written 21 years ago now, that the future of surgery was going to, one, ablation over excision. that tumors weren't going to be continued to be cut out, but ablative procedures would become the preferred therapy for cancer. Image guided over direct vision. So in other words, we're used to having big incisions and looking directly within a body cavity, that would change in favor of image guided approaches, both fluoroscopic as well as video assisted. The third would be reconstruction without suturing. The most difficult thing to do by a minimally invasive approach is to place sutures. So alternatives would be found to suturing. And then access via a natural orifice or a blood vessel over incision. Now, mind you, this was written early in 2000 and published early in 2001. And then in 2002, in came TAVR. And TAVR had 3 of those 4 principles in place: image guided over direct vision, reconstruction without suturing, and access via a blood vessel over an incision. And when I wrote that article, I had never heard of TAVR, never dreamt of TAVR, never would have invented TAVR. Yet there were people smart enough at that time beginning to figure this out and embracing those principles. So it's something that that I never have forgotten. And it also changed the way that I thought, because as a surgeon, I knew too much. I knew all the reasons why TAVR would fail and didn't think far enough to be able to think the why it would be a success. Well, how can you put in a valve without looking at it? Surely you have to cut out the old valve. Well, if you don't, all that stuff's going to go to the brain. And how do you keep this in place without stitches? Like I say, I never would have thought of this, but again, I had all the principles in place just from talking to other people. So the next principle is that it's like in baseball, the tie goes to the runner. Now, what do I mean by that? I mean that when you have 2 options and the outcomes are roughly the same, a less invasive approach beats a more invasive approach any day of the week. Why would you do something more invasively if you can accomplish the same thing less invasively? Now, the key to that conundrum, of course, is, are things really the same or close enough to the same that you can justify a less invasive approach? But the principle nonetheless is true. And again, I'll come to TAVR here. If a less invasive approach is non-inferior to a more invasive conventional procedure, then by definition, it's superior in the mind of the patient and in the mind of the referring physician. And indeed, I think we've seen a huge body of evidence of the non-inferiority of the TAVR procedure to the SAVR procedure, at least before we know long-term durability. And the same thing is true of coronary revascularization. If the outcomes are the same, why would you ever choose bypass surgery compared to PCI? And again, you can argue what are the outcomes that you care about. And if you look at 10, 15, and 20-year outcomes, you may be better off with surgery, but patients don't make that decision nowadays. They prefer the less invasive approach. So what I'm going to discuss is the future from this point. And I'll address, and I think that the future is in subspecialization within surgery. First, in the area of coronary artery disease, I think that a mistake we made as a specialty is not treating coronary artery disease as a specialty in itself. It was a generalist procedure, something every cardiac surgeon did. It wasn't like mitral valve surgery that developed a specialty unto itself. And I think that if we had developed coronary specialists, the field would have been much better served than it had been by everybody. Any card-carrying cardiac surgeon can do a bypass operation. I think we would have had more arterial grafting. I think we would have had more off-pump cardiac surgery if surgeons had embraced it as a specialty. The other specialty areas are valvular heart disease, and I think aortic valve and mitral valve are different. Thoracic aortic disease, advanced heart failure, both from a standpoint of transplant and mechanical circulatory support, structural heart disease, arrhythmia surgery, congenital surgery, and now a huge expanding area is adult congenital cardiac surgery. There are now more adult congenital operations performed than congenital operations within the specialty. So in the remaining time, I'm going to focus just on 4 of these areas. The first is coronary revascularization. The second is valvular heart disease. The third is thoracic aortic disease. And the last is advanced surgery for heart failure. So first, coronary revascularization. This is the latest STS, Adult Cardiac Surgery Database report in 2020, and it shows the breakdown of cardiac surgical procedures in the United States. You can see that despite the tsunami of percutaneous intervention for coronary disease, that 55% of all cardiac surgery performed is still coronary artery bypass grafting. 9% is aortic valve replacement, about 8% is mitral, and you can see the number of other procedures done there. So it's still a specialty overwhelmingly devoted to coronary revascularization. In 2019, there are about 300,000 cardiac operations performed in the United States, with over 160 coronary artery bypass grafting procedures. So it's a ratio of about 1 to 3 to 1 to 4 of CABG to PCI in the US. Now, as I mentioned, total arterial revascularization or multiple arterial grafting is still done in only a minority of patients, approximately 8 to 10% of all patients. And the reason being is technically it's a more demanding operation, and cardiac surgeons are risk averse in the era of public reporting and scrutiny of outcomes and reluctant to get out of their comfort zone. So still the standard operation is a lima to the LAD and 2 or 3 saphenous vein grafts. And the cardiology specialty is appropriately said, well, if you're going to put a vein graft on a particular graft, I can do just as well as a stent. And that probably is true. So there has been a new trial that we have just completed looking at an external scaffolding or support for saphenous vein grafts. And this is called it's a nitinol scaffold that goes on the outside of a vein graft. Through the CTSN trial, of which Mount Sinai was the data coordinating and clinical coordinating center for. This device, as you can see on the right here, placed on a saphenous vein graft, provides external support and at least measured by late luminal loss, seems to arterialize a vein graft by preventing intimal hyperplasia from occurring because of this external support. So I think the trial's been completed. The results were presented at the American Heart Meeting in November of this year. Hopefully, if the early pretrial studies are true, and we can really convert a saphenous vein graft to an artery by the prevention of intimal hyperplasia, I think that will be a significant advance in cardiac surgery. Hybrid coronary revascularization was something that over the last 25 years always made sense to me, but never has gained a lot of traction. If you could do the thing that we do best in cardiac surgery, and that's a lima to the LAD by a robotic or minimally invasive approach, and then stent the remaining vessels, then it seemed to me you would have the best of both specialties. However, despite multiple attempts, it has not gained widespread traction, and an NIH trial looking at that was not successful in enrolling. Yet in many isolated centers around the United States, it is the preferred approach for multivessel coronary artery disease. I'm not going to go a whole lot into valvular heart disease, with the exception of mentioning a few areas that I haven't already in the initial parts of this talk. And the first is that an area that's a prime focus of cardiac surgery is the treatment of infective endocarditis, especially in the drug addict population. As you can see on the left side here in red, the number of infective endocarditis in drug addicts is skyrocketing, and since 2016 has only continued to increase. And indeed, in many centers, especially in the South and the Mid-Atlantic region of the United States, it is epidemic. And we do multiple operations a week on patients with endocarditis, and the majority of them in drug abusers. This is another interesting approach from a surgical standpoint. This is a device that goes on the outside of the heart in patients with undergoing coronary artery bypass grafting and have concomitant ischemic mitral regurgitation. The standard operation for this nowadays is CABG plus mitral valve repair or replacement. And it is the highest mortality procedure performed in the United States. If we can find a way to make this a less invasive approach, and in this, putting this device on from the outside is just starting trials in the United States right now, has the possibility of decreasing the morbidity of that procedure. An area that's continuing to increase in frequency is the surgical explantation of TAVR devices for structural valve deterioration of TAVR devices. And with now 70 to 75,000 a year performed in the United States, it's only inevitable that after one or two TAVR procedures in younger and younger patients, that more of these patients will be presented with surgery. And this is just a couple pictures of what the degenerated TAVR valve looks like at the time of surgery. And here's a couple of other examples. And from the early experience, it's a more complicated procedure, especially with the self-expanding devices that take up a lot of the aortic root, requiring replacement of the aortic root with difficult reimplantation of the coronary arteries, as well as a surgical aortic valve replacement. So this is a procedure that's going to only increase over time. I'm glad that I'm at an age and a generation that when this hits within the next 5 to 10 years, that I won't be in the center of the fight anymore from this standpoint. But clearly, complex aortic valve and aortic root operations for degenerated TAVR valves are going to be a large part of cardiac surgery going forward. And again, this is just some other examples of how complex the root is in patients that have had a previous valve procedure. And this just shows the number of these performed. This is an article from the University of Michigan. Mitral annular calcification is a procedure that is a disease that vexes both cardiology and cardiac surgery from the complexity of the procedures needed to treat these patients and the debility that a number of these patients present with. This has been treated over the years with conventional surgical approaches, as well as now transcatheter approaches. However, there are problems with a transcatheter approach from left ventricular outflow tract obstruction. This is an alternative that's been developed to be able to address those issues. So you're looking in the left atrium through the anterior leaflet of the mitral valve, which is sphenixized, And this is a septal myectomy that's being performed by a robotic approach to open up the left ventricular outflow tract. And then a felt can be placed around the annulus and sutured in place. And then after that's in place, under direct vision, a balloon expandable TAVR valve can be placed under direct vision without concerns about obstruction of the left ventricular outflow tract. And I think that in patients that aren't candidates for a catheter approach because of left ventricular outflow tract obstruction or significant chance of paravalvular leak, this has become a viable alternative in a significant number of patients, and allowing a number of these patients to be diseased, to be treated. And you can see the TAVR valve in place there. Moving on to thoracic aortic disease. I think that the majority of descending thoracic aneurysms are now treated by a endovascular approach. And now the specialty is moving on to the aortic arch, and now the ascending aorta. And there now are a number of trials going on in the United States of the endovascular repair of ascending aortic dissection. Then here you can see a patient on the left. This is one of the early published cases of a type 1 ascending aortic dissection, and a TEVAR approach for it successfully performed. There are a number of TEVAR devices now that are designed specifically for the ascending aorta. The other aspect of it is hybrid approaches for the treatment of acute ascending aortic dissections that, you know, the overwhelming majority, 95%, still require a surgical approach. But this is what's called a frozen elephant trunk procedure. And this is a hybrid graft in the center there, in which you can see a graft that goes in the ascending aorta with separate side branches that go to the head vessels, so that a simplified version of the operations you see on the left can be performed. But what's intriguing about this is the fact that the distal anastomosis is a hybrid stent, so that the distal part in the center here can be sewn to the aorta at this point, and then the remaining is a self-expanding stent, and endovascular therapy of the rest of the aorta can be treated by this approach. And this is a more and more common procedure being performed. Complex, as I mentioned, the circulatory arrest for arch procedures is becoming less and less frequent because of the invasiveness of the procedure. And TEVAR approaches to the aortic arch with debranching procedures are more and more commonly being performed. So in other words, you perform a bypass operation of the head vessels to protect it, and then you can cover the head vessels with a stent, as you can see here, but you're protected because those vessels have been bypassed as the first stage of a procedure, or an occlusive aortic dissection as the first part of a procedure. And this is an area that is continuing to be increasingly utilized. And then finally, where the goal line is for all this is an endobental procedure. And what I mean by that is a bental procedure is replacement of the aortic valve and root, which is all done surgically. But now there are increasing interest in replacing both the ascending aorta and the aortic valve by an endovascular approach. And there are a number of reports of this procedure now being performed, so that the whole length of the aorta now has the promise of being able to be treated by an endovascular, a non-open surgical approach. And then I'd like to lastly talk about the role of surgery in the treatment of advanced heart failure. This is the number of heart transplants performed in the United States. For a number of years, it was kind of plateaued at around 2,000 to 2,200. But recent changes in the organ allocation system in the United States has actually been effective in terms of making the number of donor hearts available and usable. So the number of heart transplants done in the United States is somewhere around 32 to 3,400. It declined slightly last year from the year before. But now there have been over 85,000 heart transplants performed in the United States, and the median survival is now greater than 13 years. But despite this, and despite the recent increase, there is a limited donor supply, and hence the focus on long-term assist devices. And the most common long-term device is the Heartmate 3 device you see in the upper corner here, with a number of other devices, both short-term and durable long-term devices. So this is the Heartmate 3 device that you can see goes into the apex of the heart with a pump that's connected by conduit to the ascending aorta, with an external control device. And this shows the progress that has been made over the last 15 years in mechanical circulatory support. So on the bottom, on the right side, is the results with the Heartmate XVE, which showed a 2-year survival of about 24%. This was the device that was initially approved in the United States. And now you can see the results with the Heartmate 3 here at the upper line, that there's now an 83% 2-year survival with Heartmate 3, rivaling that of heart transplant now, and significantly better than the other devices previously. This looks at the 1-year survival now of all left ventricular assist devices, and the 1-year survival is 93% at the current time. And if you look at now at the survival of left ventricular assist devices versus heart transplant, you can see that at 2 years, the results are the same, with some decrease after that. However, these are all devices, both bridge to transplant and destination therapy. And it's reason to think that the long-term survival now is approaching that of heart transplant. As a matter of fact, to the CTSN network, Donna Mancini, within the last couple of years, has actually proposed consideration of a randomized trial of heart transplant versus left ventricular assist device. So you can see how far this field has come, and it will only continue to grow. The number of LVADs performed in the United States is about 2,500 to 2,700. It took a slight dip in 2020 because of the pandemic, but with new devices and better longer-term outcomes, this will only continue to grow. The other problem with mechanical circulatory support is that LVAD devices only address the left side of the heart. And about 25% of patients will develop right-sided heart failure over the course of their devices being in place. So there is a need for biventricular support that those patients that either develop right-sided heart failure or are at risk for right heart failure. And this is a device that's about to start early feasibility studies in the United States. The CARMAT, a total artificial heart, invented by Alain Carpentier. And this is a very unique device. It is totally a biologic covered device, that there is no foreign surface. that comes in contact with the blood to minimize the Achilles heel of mechanical circulatory support, and that is thrombus generation requiring anticoagulation. But it is an electrically driven pump with an internal sensor in place that provides auto-regulation. So unlike current mechanical circulatory support that you set the cardiac output, this has a physiologic response based upon the amount of blood coming back to the heart, and the device adjusts the cardiac output based upon the cardiac filling. It is a relatively straightforward device to implant. The old heart is excised, as you see on the left. Two cuffs are sewn in place to the left and right atrium. A bridge is placed between those two devices, as you see on the right. And then this device is snapped into place, and then two grafts sewn onto the ascending aorta. And then you can see it's connected to an external battery pack here. All the controls are internal. So that is promising. It's been approved for 10 procedures in the United States that have been delayed a little bit because of the restrictions with COVID, but those implants should happen this year, starting within the next few months. And lastly is Ecmo, or extracorporeal membrane oxygenation. This has been a increasing focus of cardiac surgery over the last number of years, but especially with COVID in the last 12 months. These show the number of centers in the United States, that there are approximately 120 centers that perform Ecmo on a routine basis. And as you can see, that there's about 16,000 procedures performed. This was prior to the COVID era. Ecmo has been found to be quite effective for COVID, despite some early concerns that it was not. I think that everybody has gotten a lot more intelligent about figuring out who is appropriate for what therapy with COVID. However, there have been almost 5,000 patients in the United States treated with Ecmo on COVID, with a in-hospital mortality of about 47%. And indeed, that's been our experience now, with over 50% of patients placed on Ecmo for COVID surviving to hospital discharge. And the requirement for support is much longer than with traditional Ecmo, with a number of patients requiring 25 to 30 days of support. So we've gone to procedures where we now change to neck cannulation after a patient has stabilized, so that they actually can sit in a chair and begin to ambulate while on Ecmo to support their rehabilitation. And this is the current report of COVID-19 Ecmo survival. And as you can see, the number of patients being discharged either to home or to a longer-term care facility or discharged is increasing significantly, with the number of patients dying staying relatively stable. So lastly, in the time remaining, I'd like to put in a pitch for the heart team that a number of people know that I've been supportive about over the years. And I think that this is a key to the success of both of our specialties. I lived through the era of the Cabbage versus PCI wars, where cardiac surgeons and interventional cardiologists were more foes than friends. As there are multiple examples, when folks don't work together as a team, the results aren't always optimal as you would hope. So this was driven home. This is the Steve Jobs biography by Walter Isaacson. But when he was being treated for his cancer, there's this narrative in the book. I realized that I was facing the type of problem of my oncology care that I never permitted at Apple. My treatment was fragmented rather than integrated. Nobody seemed in charge of figuring out how nutrition was related to pain care, to oncology treatment. I was being treated by all these ologists and not being coordinated in a cohesive way. So he convened the team of various Stanford specialists at his house to coordinate treatment. Now, I don't think there's probably only 2 or 3 other individuals that could convene the team at his house. But this is a very insightful way to view how an outsider views the way that we deliver healthcare in a non-coordinated, non-cohesive way. The fact that he had to convene the specialists himself to all get on the same team. So it is an interesting insight. And there are areas, of course, of healthcare that it work extremely well with multidisciplinary heart teams in virtually every specialty. So rather than having silos of care, in which a patient's treatment is often determined by what door of the hospital they walk into. If they walk into an interventional cardiologist office, the recommendation may well be PCI, a general cardiologist, medical therapy, and the same patient walks into a surgeon's office, CABG may be the recommendation. For aortic stenosis, be it TAVR or SAVR, hybrid procedures, mitral valve repair or replacement based upon what surgeon's office they walk into, or now increasingly MitraClip. So it's a fragmented approach to some degree, dependent upon what door of the hospital you walk into or whose office that you walk into. And that doesn't make a whole lot of sense. So what we have embraced since the beginning of TAVR is a multidisciplinary valve clinic. That's a collaborative approach that gets all care providers and patients together at the same time. The patient makes one trip to the hospital, gets to see all specialists, and gets a decision. And although in the early days of TAVR, this was used for all patients, it's used for complex patients right now, which there's not a clear answer on the front end. So our heart team is 6 surgeons, 4 cardiologists, interventional cardiologists, and 3 imaging cardiologists. And this is the way that we run the clinic. So this is our mitral tricuspid clinic that you can see that everybody convenes together. Of course, there's logistical issues and everybody's busy, but we have found that this has been the most effective way of reaching a patient-centered, multidisciplinary approach to decision-making. And we've taken this approach and now developed a disease-based approach to the multidisciplinary clinics. It started with a TAVR clinic, expanded to mitral and tricuspid. We now have a thoracic aortic clinic that includes both thoracic surgeons and vascular surgeons, complex coronary disease staffed by surgeons and interventional cardiologists, as well as a general cardiologist, advanced heart failure and mechanical circulatory support, and now an arrhythmia clinic, both for atrial fibrillation as well as ventricular tachycardia. So the future of the heart team won't be figuring out who's on top. Is it cardiologist or surgeon or cardiologist? That is not a formula for success, but we need to figure out a way to keep this together when there is a increasing sense of do we really still need each other as a lot of these procedures mature and become more defined? And I would make the case that yes, we still do. So how does all this add up? Well, when I started out my career in medicine as an internal medicine intern at the University of Minnesota in 1973, and as I look back, the acute MIs were treated by a 1-month stay in the hospital because there was nothing else to offer. Surgical hip operations took 6 weeks for recovery. There was no such thing as a knee replacement. There was no cure for acute leukemia. Cholecystitis required an open procedure and 6 weeks of recovery. Heart transplants had gone from headlines and were abandoned except at Stanford. And there was no specialty of interventional cardiology. and heart valve surgery was still uncommon at that time. And I looked like this. Now, what's happened since then? Fast forward 48 years, and 90% of the operations I did at the beginning of my career have changed. And if you look at medicine overall, mortality has now, from heart disease, has now declined by 50%. Total hip replacements are routine, and you can do bilateral total knee replacements as an outpatient procedure. Most leukemia is now cured. A lap chole is an outpatient procedure for cholecystitis. Heart transplants and VADs are now routine. And you can get a percutaneous heart valve and go home the same day, something I wouldn't imagine at the beginning of my career. And 48 years later, I got a haircut. So cardiac surgery has an incredible legacy of innovation. It has thrived based on this innovation and has continued to, as I say, stay one operation ahead of extinction because of this innovative, inquisiting individuals within the specialty. So the final word is there is nothing more difficult to manage, more dubious of success than to initiate a new order of things. The innovator has enemies in all those who profit from the old order, and only lukewarm defenders in all those who would profit from the new order, said by none other than Machiavelli. So I would close by just saying, as Mark Twain said, rumors of my death have been gradually exaggerated. Cardiac surgery is alive, well, thriving, and has a great future. Thank you very much for inviting me to give this lecture, and I hope that you found it somewhat insightful.
Thank you very much, Dr. Mack. That was a phenomenal talk. You covered phenomenal sort of past, present, and future as one of the few people who could really have that perspective. But I was very intrigued by what you said, Dr. Cooley said in the beginning, of allowing the pedestrian surgeons access to the new technology. Do you think that he may have had a point there, that we should have centers of excellence, as Dr. Adams has demonstrated with mitral valve, outcome are better. And in, let's say, New York City, where you may have 10 different places doing open heart surgery and 15 places doing TAVRs, should we really centralize it to a few centers of excellence which would provide better outcome rather than disseminating the technology into the hands of people who may not have the skill set to really perform it as well?
So you identified the key tension that is in place in healthcare delivery, and that's the tension between quality outcomes and access to care. And clearly, the best interest of every patient in the United States with mitral valve disease that needs surgery would be coming to Dr. Adams at Mount Sinai. No question about that. The problem is, as hard as David works, he can't take care of everybody in the United States or in the few centers that have outcomes similar to Mount Sinai. So you have to balance the access to care, and what you have to do is to determine as best possible how you can scale that same quality of care outside of Mount Sinai in New York. Now, are there too many centers in the United States providing invasive cardiac care? Of course there are. There are 1,150 cardiac surgery programs in the United States doing cardiac surgery. A couple hundred of them do less than 50 procedures a year. So I don't care what you do in life, if you only do it once a week, you aren't going to be very good at that. I initially thought that the number of centers that needed to perform TAVR in the United States was about 4, maybe 500 at most. But there are now 800 TAVR programs in the United States. Is that too many? Sure, it probably is. However, the fact that the procedure has been made as technically straightforward as it has, you're probably better off in a small center in the United States getting TAVR than you are surgical aortic valve replacement. So it's always a balance of access to care versus maintaining quality outcomes. Despite the fact that we have come up with valve center documents that define primary or basic centers of care and comprehensive or tertiary centers of care, such as Mount Sinai, there is incredible public demand to keep care as local as possible. So yes, Dr. Cooley was on to something there, but it's always the tension between making the healthcare delivery available to as many people as possible, yet maintaining the highest quality possible. So I know that was a long-winded answer, but it is a constant tension that goes on. There are 50 heart surgery programs in Dallas-Fort Worth, where I live, more than the whole country of Canada. Does there need to be? Of course not, but despite our best efforts, we have a hard time closing down the smaller program.
Thank you.
Mike, I would like to know how would you train the surgeons of the future? Seems to me it's becoming more and more complex, the type of procedures that you're talking about. Are you going to have people, surgeons that would like to be trained in the same way in the past? Is going to be less? It seems more difficult. So tell me how do you view the training?
So I think the training, Dr. Fuster, does have to change significantly. And indeed, the American Board of Thoracic Surgery is now evolving a new training program or training paradigm to address that. At the current time, to be trained in cardiac surgery, you need to be trained in both cardiac and thoracic surgery. So chest surgery as well as heart surgery. So that's going to change this year. And there will be a track that you can train specifically in cardiac surgery. So that's a significant step forward. The second, as I alluded to, was subspecialization. So there has been the move towards super fellowships now. And a lot of this has to involve a transcatheter therapy. I don't think that the world doesn't need more transcatheter specialists right now per se, but I think surgeons with those skills, like for example, from all the skills that I learned of large vessel closure and ultrasound guided access to femoral arteries, we now use in cardiac surgery to percutaneously put a patient on coronary bypass or percutaneously put a patient on Ecmo without a surgical cut down, specifically because of what we learned from endovascular approaches in cardiology. So I think we're going to see, specific cardiac surgery training and then subspecialty training. You can't do mechanical circulatory support and heart transplant without a fellowship now in advanced heart failure care. The same thing for valvular disease. Hopefully we could get there with coronary revascularization, but I think that that's the answer as to how to train in the future. Cardiac specific and then super subspecialization.
By the way, great talk.
Oh, thank you.
Superb.
Thank you, Valentin.
Dr. Mack, it's Roxana. Thank you for your wonderful, wonderful talk and kind of really seeing the future back in 2001. It's really incredible. I'm going to go back and read that JAMA article. I wanted to talk to you also more about where you think we're going with the use of these. You're very, very much involved with a lot of research using these big data, access to big data through STS, TVT. How can we do better? I feel that we're still, as somebody who reviews a lot of these papers and has written a lot of these papers, I feel like we can do a lot better than where we are. How do we get these data banks to talk to each other without any difficulty that we're currently encountering, and how we can do better research? And then secondly, in the pragmatic trial designs that you and I have been involved in, everyone talks about this with use of these large types of registries to try to bring the future closer so we can work better together, but yet I don't see it implemented. Where do you see the future there?
So, yeah, two real easy questions, Roxana. And I know that we're up against the end of time here, so I'll try to answer briefly. The second one first, the pragmatic clinical trials. Everybody's made sense that everybody's made the case we need Sweetheart in the United States, similar to the National Registry in Sweden, and that you can randomize patients in a registry-based format. We have struggled immensely to try to implement that in the United States. That has not been successful because we don't have a national registry and a single payer that captures all data. We've struggled to find the right question to ask that that people would care enough about and that is executable in that format. And that's something that you do a procedure and you can follow up the outcomes in a registry-based format and don't need to determine medication compliance and things like that. So that has been a very elusive platform and trial to be able to implement despite a lot of smart people's best efforts in terms of doing that. I think the answer regarding big data is, as Dr. Fuster well knows, if you want to try to get your paper published, you either put COVID in the title or you put artificial intelligence or machine learning. It just seems like every paper that's submitted has that now, but again, that has proved elusive. The problem with any big data is you have treatment bias in terms of trying to do comparative effective research. There is a reason that clinicians chose a particular therapy that can never be accounted for despite how large your data is, as well as the sophisticated matching techniques to be able to compare the outcomes. I was virtually at a think tank last week at Duke Margolis in North Carolina regarding the new tier NCD and what's called MCET, and the Chief Information Officer of United Healthcare just said, well, we're just going to merge all insurance claims data together, and we'll be able to link those to EHRs, and that's the answer to developing evidence. Well, yeah, great idea, clearly aspirational, but not going to happen in the time that you and I continue to practice, Roxana. So
a lot of work to do. You're so right.
Huge questions, difficult answers.
Mike, just to follow up on that point, yeah, you and I wrote an editorial in Jack a few months ago about the need for long-term follow-up to really understand the evidence base and the advice we're giving patients. Because it seems to me like the last 10 years, we've sort of been in this era of less invasiveness. Some of which, by the way, have not caught on. You've talked, for example, if you look at robotics, patients come to me every day acting like robotics is a new thing. I always remind them it's in year 21. This is an old field, not a new field. But like you say, in cardiac surgery, if you want to be sexy, you say the word robotic. It's like COVID now in the cardiology community. But I was going to say that the one point you and I made, which I think is so important, and I hope the heart teams get back to it, which is, it's not just your invasiveness, it's whether you've cured the patient. And I think that we're going to learn a lot the next several years in the valve arena about, as we move toward younger patients, about durability of what we're doing to them. And I think this is where you're really going to need the balanced discussion among specialists, not just the specialist to patient, but between specialists about, dealing in life expectancy and that sorts of things when we're trying to make these recommendations. What do you think?
So you're absolutely right, of course, David, and probably the best we can do with our systems in place is to be able to have our electronic health record auto-populate clinical registries. And there is a lot of work that's going on there so that we can decrease the burden of filling out all these registries by just having an EHR auto-populated. Again, that's aspirational, but it is much closer that probably within the next year or two, we'll be able to have at least 20 or 25% of the fields populated directly from an EHR, so you don't have to have separate data entry. And then take those clinical registries that are granular enough that you know what was done and why, and link those to long-term administrative claims data. So link them to Medicare data, and that's worked well for TAVR until now, but there's a lot of problems right now from CMS with linking those claims. But also, as you move out of the Medicare population, there's not one single database that you can link to. There's a lot of big data efforts such as Optum that's looked to try to do that. But you're right, to do a truly effective comparative effectiveness, you need long-term outcomes. And the ultimate solution is to have an EHR that auto-populates a registry database that's linked to administrative claims data.
Mike, the other question I wanted to follow up on was this one about centers of excellence. And we'd always talk about access, and I don't want to talk about the access in the suburbs or in communities that are less populated, but how do we handle this inside large health systems? And I know you've worked a lot on that in your own health system, which you help run with several different hospitals, because this is one thing that I feel like as the outcomes have gotten so good with high volume and experienced people, it's very hard to justify low volume procedures in hospitals in your own health system that are not, hundreds of miles away, but a few miles away. And how do we tackle that as organizationally and also just as a heart team that's actually sort of, aware of this? How do you do this? It's not easy, I can tell you.
Well, there's, it's a two-pronged answer. One is when you have competitive health systems, patients very seldom going to leave one healthcare system and go to another. So I can have the best program in the world and there's a competitive healthcare system across the street. It doesn't matter how good a job I do, that patient's not going to leave that healthcare system and come across the street. So the best thing that we do is care system. So, we have 8 cardiac surgery programs. We now have 6 TAVR programs and 4 MitraClip programs. And we truly do have a system-based approach in which we try to help determine what patients can stay locally and get a good result versus which patients need to be referred. So this idea of a primary versus comprehensive center. Again, realizing that everybody from Temple, Texas, where your friend Ram Reddy is not going to travel to Dallas to get their care. But if everybody is on the same page and not threatened that the tertiary institutions are predatory and trying to take their patients, but trying to help them be better, that's the approach that we've taken, and hopefully we've had some degree of success with that.
Well, Mike, thanks a lot for joining us.
Well, thanks, David. Appreciate being able to do this.
Mike, I'll make one other comment. Maybe you can make one more future prediction for us. You and I have been working shoulder to shoulder in the mitral space now for several years. It's pretty hard. in terms of the, I was saying the other day, if you think of all the billions of dollars and all of the patents and all of the investigators and all of the drawings on the backs of napkins, actually very few patients have been intervened on with mitral devices so far. I mean, it really is been tricky at a lot of levels. And I'm curious what your thoughts are about what do you think this is imminently solvable? Is this going to be a much longer, slower climb? What's your current view, particularly about degenerative valve repair?
It's going to be a much longer, slower climb. I think that that TAVR in a lot of ways was a unicorn. It's to expect TAVR redux is really unrealistic. It set an unrealistically high bar of success. And there were reasons for that. And one is that you were treating one disease, calcific aortic stenosis. Now you can argue that bicuspid is different than tricuspid. You basically were treating one disease.
One lesion.
And mitral isn't that way. It's multiple etiologies, much more complex. Delivery is much more of an issue. So it is going to be a much harder lift and a much longer process for clinical adoption. The other part of it is when TAVR failed, the results were immediately obvious. The patient died. That's not true with mitral valve disease. You can get, patients don't die from that procedure because it hemodynamically is not that adversely affecting. You can get through a procedure yet die because you got an inadequate correction of mitral regurgitation. You languish with ongoing heart failure. So that the failure mode is not as obvious. Therefore, the outcomes in the real world aren't going to be nearly as apparent as they are with aortic valve disease. And hence there's a lot of bad, both mitral surgery done out there and a lot of bad MitraClip therapy done out there. That takes time for that to become obvious.
Big data. Thanks, Mike.
Sure, David. So, Marty, I think you're speaking, but I think you're on mute.
Eric Stern here. I'm Associate Program Director for the Cardiology Programs. I just want to thank you very much, Dr. Mack. I think people are dropping off and I don't see other questions, so I think we should not keep you on the hook any longer.
Great, Eric. Well, thank you very much. Appreciate you having me, and best to everyone, all my good friends at Sinai.
Thanks a lot,
so
Mike.
much.
Bye, everyone. Thank you.
Bye.